Hello healers, my name is Ben and this is the Moss Report. It's almost 6 a.m. here in Connecticut and Liz and I are getting ready to get on the plane to go to Cabo San Lucas and visit with the first of the clinics that we're going to be stopping in and seeing in Mexico. So we're headed to JFK and we're going to try to document our trip the best we can and bring back all of that information. Hopefully that'll be helpful to you folks out there. So let's go. So we're on their way from the airport to the hotel. We got the driver that came and picked us up. Very nice man, sent over by the clinic. Good morning, healers. What you hear in the background is the crashing of the waves on the beach in Cabo San Lucas. Here, I'll give you a look. I'm here with my lovely wife, Elizabeth. Our goal here is to provide unbiased reporting around cancer clinics, what they offer, and whether they would provide good value, both in terms of the experience, the cost, and the effectiveness of their treatments. So it's a legacy of reporting around these topics that was started by my father, Dr. Ralph Moss, almost 50 years ago. And it's a generational affair now, and where I'm picking up, I want to continue to do that, reporting justice, by having the same unbiased type of look and approach that he's had all these years. I take that responsibility seriously. I'm here to do that for you, and I hope you'll be following along as we visit with these clinics and find out more about them, and hopefully find some ways that you can also have a healthy life ahead. Well, Liz and I are going to try to take a look a little bit around some of the downtown area, Cabo San Lucas.
We have different milligrams of that you can a luxury clinic. Good morning, healers. My name is Ben and this is the Moss Report. I'm here with my wife Elizabeth and Eduardo Cortez, representative on behalf of the Williams Institute here in Los Cabos, at Los Cabos Hospital. I understand we're going to go inside and have a look at one of the procedures that Dr. Williams is performing this morning.
That is correct. We will be looking into a procedure with ablation and interventional immunotherapy. This one will be an ultrasound guided procedure for a breast cancer patient. So breast lesion will be the target. And we'll be looking into the procedure room where we mostly perform the treatments. Is a CT room. where we can also use ultrasound guidance and of course, if required, CT to really make and targeted treatment.
Targeted.
Yep.
So the accuracy.
Accuracy is always
Right.
of importance. So you have to see what you're treating. Otherwise, yeah, you will be blind.
Understood. Okay. Well, we'll go and get into it.
Yeah.
Eduardo,
Yes, sir.
would you kindly tell us a little bit about this procedure and what makes it different from other types of procedures? Well, this is an ablation procedure?
Correct. So we will be performing a pulse electric field ablation, which is a delivery of high energy bursts that will modify the structure of the cell and allow for a response from the immune system. So, but this also functions as sort of another immune stimulating factor in order to promote this response against cancer.
I see.
So what will be done is a series of separate cycles and within tumor or within the area of tumor before the introduction of the immunotherapy agents that will be injected in the same area.
I see.
Of course, this is all part of the process, again, to try to create or generate the systemic response against the cancer. And so you have to have a viable tumors that could be ablated and then injected in immunotherapy.
I see.
Not all cases would require ablation, depending of course on the position, the area, the size of them might change, but that would be some of the factors to consider when consulting with a patient.
Mm-hmm. So the use of the pulsed electromagnetic field,
Pulse electric field, yes.
that is not intended to actually destroy the
It does
cancerous tissue?
have an ablation part of it,
I
so
see.
the tumor killing process.
Okay.
Although it's not a large area as you would think of give me one second.
Okay. So we're in the operating room right now, and we're watching Dr. Williams perform this procedure, wherein they use electrical pulse to do an ablation, which is the same as sort of burning the tissue inside of a cancerous growth, in this case in the breast. And my understanding of what Eduardo was just telling us was that in addition to that procedure, which does help to destroy some of the cancerous tissue, one of the other primary objectives is to be able to introduce immunotherapy drugs through the same tube which they're using to insert the electrical probe. I believe that this procedure was developed by Dr. Williams himself, and the idea is to create a systemic response with the immunotherapy, as well as to destroy some of the tumorous tissue through the use of the ablation. It's fascinating.
I'm gonna be talking because I got this microphone, so I'll just be
okay.
talking. So, don't think I'm talking to myself.
Okay.
So this patient, she has actually a long history of advanced breast cancer. She's actually gone on about 12 plus years. We've treated several times when she's been a real advanced state. She's actually improved a lot, but one issue she's got is she's got some lesions in the sternum that have broken some of the bone in the sternum. She also still has a lesion in the breast. Other areas are starting to look good, like her lungs and some lesions she had in the abdomen. But we're going to treat more on this breast lesion because we can get immune stimulation through this by doing the pulse electrical field ablation and then doing intratumoral immunotherapy. And then we've already did pulse electrical field a few days ago on the sternum, and then we'll come behind and put a bone cement to help hold the bones together so that she doesn't have pain from there, because that was one of her issues, was the pain. And unfortunately, when she was at home in the United States, nobody really wanted to do anything to help her, so we've got to try to take care of all the main issues. So initially, I use for the breast, I use ultrasound. Go in and first numb up, even though the patient's sedated. We still use lidocaine. It's actually been shown that injecting lidocaine into the tumors, not only does it help with the pain, but it actually has anti-cancer properties, actually boosts the immune response. So when you combine and doing intratumoral immunotherapy or ablation, you actually want to numb or put some lidocaine into the tumor itself. Okay, I think we can treat there. So with the pulse electrical field, the thing this is done particularly to stimulate an immune response. It's not just to try to kill cancer, even though you are killing cancer. And it's not like some other ablation techniques where you go and you try to kill 100% of the cancer. We actually know if you kill too much cancer, it can be immune suppressing, probably because you're releasing too many dead pieces of tumor, and the immune system will get overwhelmed. And the other is that we've actually done some studies looking at this where the residual tumor actually begins making immune stimulating substances itself. So it's really interesting. It's like a self-destruct. So by partially treating the tumor, you get a better immune response. Okay, we can step on it.
Okay.
The pulse electrical frequency sends a very high voltage charge that's like 1/1,000,000th of a second into the tumor. That opens up pores of the membrane. It opens up pores in the organelles, the structures inside the cell, and the cell dies in a very immune stimulating way. Some of it is ferropoptosis, probably other aspects as well. The thing that we've seen with pulse electrical field is that you get generation of what are called tertiary lymphoid structures. These are groups of immune cells that get around the tumor, forming almost like lymph nodes, but they're basically like little military bases of the immune system, sort of organizing their attacking cells all around the cancer. And this pulse electrical field, of all the ablation technologies that we know and have used, this one seems to be the most immune stimulating. And of course, when you combine it with injection of immunotherapy into the tumor, that's even enhancing it further. So it's really pushed the field along a lot with this. This is newer technology that was FDA approved last July, so 2022. Okay. We'll do one more and then we'll inject.
Okay.
And then we'll inject the sternum after that, yeah.
Okay.
Yeah, the problem in the sternum is with under fluoroscopy you can't see it quite as well. It keeps changing back and forth. But we can see so well under ultrasound. This part of the tumor is softer, getting softer than what it was the other day. See how it's changed? Yeah, like particularly that's where we focused at a lot before, and look at all the brightness, the increased echogenicity. That's the one thing that's nice with ultrasound is like.
We do PET with her?
Well, we will at some point, yeah.
Okay, not right.
No, we'll wait. It's just too early. But yeah, like the nice thing with ultrasound is you can see the changes.
Mm-hmm. The coherent
faster.
of the therapy.
Yeah, faster than you see them even on CT, so you kind of know what areas to target. That's why I like using ultrasound when I can.
You see that change?
Yeah. After this one, we'll inject the immunotherapy at least. Yeah. All right. Ready to inject some immunotherapy. Oh, can you touch my ultrasound? Thanks. It's always a great satisfaction ablating tumors and injecting immunotherapy.
And see that change?
Yeah, I see a change in the tumor. It's rewarding to kill cancer right away.
De ahí ya tengo esas.
So we just got done watching that procedure take place and talking with Dr. Williams, and subsequently we had a quick chat with the patient's husband. And while we didn't record that, I can share with you that he felt as though he was in really good hands with Dr. Williams. They're confident in his approach and appreciative of the care that they're getting from him and his team. I can say from my perspective that the clinic here, the hospital, is everything seems very clean, well maintained, very professional. The staff all seem highly competent, and just about what you'd expect at a good hospital stateside. I think if I were someone who was considering the type of treatment that Dr. Williams offered, I would feel very confident that, first of all, getting in and out of Cabo San Lucas, for us it was a nonstop flight from JFK. So, yeah, a very professional, well-run operation here. If I was seeking treatment, I wouldn't have any qualms about flying in and being treated and cared for in a hospital such as this. We're on location in Los Cabos, Mexico, at Los Cabos Hospital, and we're visiting with Dr. Jason Williams, representing the Williams Institute. We had the privilege of being able to be in the operating room with him as he performed 2 different procedures on 2 separate patients, both of which involved the use of ablation and immunotherapy drugs combined. I'm also going to be joined by my father, Dr. Ralph W. Moss. The following segment is an edited version of the full clinic conversation available at themossreport.com.
Dr. Moss, good to see you.
Good to see you too.
It's a pleasure to be able to talk with you.
Same here. We have talked before.
We've talked before, yeah. Actually, I was telling Ben The first time you and I talked, I don't know if you remember, this was 2004. I remember I was at the University of South Alabama. I was on
Uh-huh.
that big long bridge by Mobile. I was on my cell phone talking with you,
Yeah.
and was discussing with you about that we were doing ablation,
Right.
and that we were seeing tumors that were distant that were shrinking or going away. And you were like, "Oh, that's the abscopal effect," which was the first time I'd heard that word. So I had to go look it up.
Uh-huh. Well, I've followed your work from afar and admired it, and I've read your book, and I thought it was excellent.
I
I
appreciate
I don't feel that way about too many books, but
that. Well,
I'm a bit picky. I'm very excited to talk to you.
I appreciate that. Yeah.
I don't know if you know this, but I had prostate cancer uh, about 7 or 8 years ago, 7.5. And I was treated with ablation
Yeah.
at New York University. They do cryoablation. So I have a personal interest in this. I know that this is, extremely promising
Yeah.
approach.
Yeah. It's definitely the future. It's been a little bit slower coming along than I thought,
Yes.
but it's gaining ground.
People should understand that there's a long history to this.
There was actually a book written about cryoablation in the 1800s. And in the late 60s, there were some prostates where I think they injected liquid nitrogen
Yeah.
into the prostate, and then got one case they reported a complete response in bone lesions.
Yeah. Yeah.
So
That's the abscopal
that's
effect.
right. For us, when we started doing radiofrequency ablation,
Uh-huh.
was in our first 10 cases, we saw two patients who had a complete response when we treated just partially. We treated a couple lesions with the plan that we were going to just keep ablating and doing it, and then some of their cancer all went away.
Yeah.
And so then we realized, okay, there's an immune response going on, and then what can we do to make it happen more? And we first started injecting interleukin 2 into the ablation site, and
Uh-huh.
interferon, and those things didn't make a huge difference. It wasn't until about 2011 we started using some vaccine adjuvants.
Mhm.
There had been some animal work done, which really helped guide our treatment, and that's when things kind of took off. And then you got the checkpoints came in
Yeah.
right behind with Opdivo and Keytruda, and we had, of course, Yervoy in 2011, and all of those really accelerated. And just now, there's so many immunotherapy options coming along.
Right.
So yeah, one of the agents that we've used, CPG, is what eventually Dr. Old, who I think worked with Coley's daughter,
Yeah.
had identified as being one of the active parts of Coley's toxins, which
Yeah.
essentially is what we call a toll-like receptor agonist. This is something that the immune system knows is dangerous, sees it as dangerous, recruits immune cells. And it's one of the issues with the standard immunotherapies. So many people now are on the PD-1 inhibitors like Opdivo and Keytruda. But if you don't have immune recruitment to the cancer, then those drugs don't have really a chance to work. And that's unfortunately one of the reasons that it fails in the majority of patients. And so CPG, being essentially single strand DNA that's found in bacteria or some viruses,
Yeah.
is recognized by the immune system. And when you inject it into the tumors, particularly in combination with some of these other drugs, recruits those immune cells, you get the immune infiltration, then now the checkpoint inhibitors can work. And so that's the thing that's really interesting. So it's like a refined version of Coley's toxins. Instead of
Absolutely.
giving the bacteria, you give the actual specific agent. Patients that come to us, a lot of times what they do, they have to submit their records and their imaging. And so we review all those and determine, if there's somebody that we can help. Usually we'll have a consult with them remotely. They can certainly have it in person if they like. And then when they come here, depending on the cancer type, so you have some situations where, let's say you had an early cancer, like a breast cancer, you could do cryoablation alone. Um, but then if you've got advanced cancer, which a lot of the patients that we treat are advanced, those are patients where we're doing ablation combined with immunotherapy, and we're repeating that. These are mostly outpatient procedures. Though sometimes the patients, if we're doing a lung, we might keep them in the hospital, but otherwise we'll treat them. They'll stay about half the day in the hospital. Obviously, we do the majority of our procedures in Cabo San Lucas, Mexico, which is a very nice place. We're in a full service hospital, and then we do these weekly. depending on the type of cancer. For example, like if it's lung cancer, a patient might need weekly for 3 weeks. If we're dealing with pancreatic or colorectals, those are more resistant. Those are going to at least be probably 6 weeks or possibly longer in some cases. And of course, we're scanning and looking at the patients throughout the process and seeing how their tumors are responding. And so that's but we're injecting directly into the tumor, so we're able to use less drug, even though we do more combinations. That has less side effects for the patients.
So which are you doing first, though? Are you doing the immune stimulation or doing the ablation?
We actually do them together, both together all the time. And one thing I just want to let you know about is there's a newer ablation technology called pulsed electrical field. And that actually seems to be more immune stimulating than cryoablation. Yeah, in the animal studies that actually beat the PD-1 inhibitors head to head with only ablation. So really immune stimulating technology. And so I think overall for a lot of cases, particularly your advanced cases, this is a better technology. It actually connects with the EKG. You place the needle into the tumor, sort of like if you're doing a biopsy. The one thing that's nice is it has a needle and a needle, so you could place a needle. Then it has an electrode that goes into that, and you target several areas of the tumor. So you do these overlapping ablations. They take about 5 to 6 minutes for each spot. That does about a 1 centimeter area volume. And so you hit those, and then you have your needle already in place, so you can inject the immunotherapy right through that needle. Don't have to place another needle, which is nice.
Yes.
And so, yeah, it's a really amazing technology. There's very few systems that we were the first to get it, and I think there's only like 7 systems in existence. But it did get FDA approval. Got FDA approval only with 30 patients. The other thing that we do in most cases is we use tocilizumab, which is an IL-6 blocking drug, and that was actually shown to reduce the side effects but enhance the immune responses. I mean, single milligram doses will actually have a major effect. When you think about it, you look at the mouse studies,
Yeah.
a lot of those are, a quarter of a milligram, a half of a milligram, and they're getting major effects with it intratumoral. And so, when you're thinking systemically, obviously there's a huge difference between mouse and humans, but actually when you're looking intratumoral, the differences are not so big because, the immune cells are the same size, the tumors are, they obviously can have bigger tumors and maybe you need to use more agents, but you can really get an amazing response with
Yes.
low doses.
No, I think you're a rare physician who recognizes this,
Yeah.
and you're on solid ground in terms of the empirical evidence.
So one of the things, of course, is that a lot of these immunotherapy drugs have very little penetration into the tumor, and so when you're injecting directly into it, and a lot of times we'll use like a gel or another agent to hold that into the tumor itself, and it'll slowly release. But then you're getting that in the tumor. You've got the potential of the tumor antigens, the pieces of tumor that the immune system's going to see. Those are actually there together with the immunotherapy, going to those antigen presenting cells,
Yeah.
going to the local immune cells in the environment. I mean, when a lot of these drugs are working on immune cells, and you really want it affecting immune cells that are around the cancer, not immune cells that are elsewhere in the body. That have no interest in fighting cancer. Technically, we started first injecting tumors probably about 2004. So we
Yeah.
were doing ablation, did
Coming
ablation
up
work
on 20 years.
before. Yeah. So we have an idea of what immunotherapies may work, but then there's a technology called nanostring, which is a DNA barcode technology, and that allows you on a single specimen, you can look at all the immune receptors. I think there's 770 different ones. You could sequence the entire genome if you want as well. You could look at all the metabolic profile of the cancer, everything, all in a single specimen, and that's really allowed us to learn a lot with these cancers, where if we're treating somebody and we're seeing resistance, then we can start analyzing their tumor and figure out why are they resistant. We do have a clinical trial right now. We've got one for prostate, and we've got one where we're doing basically numerous solid tumors to see which ones are the best responders. We kind of know that overall with the 4-drug combination, breast and lung are some of the better ones. Prostate is very good. But if we can get the 4-drug combination approved, then we can try to build on that.
On another note,
Mhm.
tell me about what you do and what what you recommend for your friends and family members in terms of preventing cancer and in terms of lifestyle.
Yeah. Well, I think one thing, the big cancer risk relates a lot to the microbiome, which of course also relates to lifestyle, diet.
Hmm.
Um, if you don't have the right bacteria in your intestines, then your immune response against cancer is not going to be as good. We know
Hmm.
that immunotherapy, there are several bacteria that are key to having a good immune response. We
Yeah.
try to get our patients really kind of tuned up. It's not just like, okay, we're going to give you these drugs and that's it. We want to make sure their microbiome's good. He's coming to get me. Yeah. Yes, I appreciate it.
I'm
Yes.
glad that we finally had a chance to.
Yeah, Dr. Ross, I
Well, we
appreciate
finally
it.
had a chance. Of very interesting, very, very
Yeah.
productive. I'm sure our viewers are going to love this
I,
show.
I, I look forward to talking more. There's so much stuff. I'll start sending you articles and things.
Sure.
There's just yeah, we could go on forever,
Yeah,
but yeah, we'll have other talks,
we
and I
sure
appreciate
will.
it.
Thank
All right,
you.
well, I'm gonna run and do my procedures.
Okay, thanks a lot.
All right,
Great.
thank you, Ben. Appreciate. Oh,
Bye.
oh yeah.
Well, this is the end of our 4-day stay in Cabo San Lucas. I want to extend a very warm and sincere thanks to Dr. Jason Williams and the Williams Institute. All in all, I would say it was an excellent trip. I think that if one was trying to find a place to do some healing, you could certainly pick a worse place to be to do that. So that's all for this trip. Next stop, Tijuana, for the Moss Report. I'm Ben Moss. How are you healing today?